Most commonly, I'm working with a hospital to help the staff understand how they can function efficiently and effectively in a system that throws so many things at them. There are surely over 300 languages that are spoken in the world and actually in the USA. So how can you feel comfortable and competent about what you're doing if you can't communicate? What are the policies and procedures that you need to make in order to allow your staff to feel good about it? Those same policies and procedures may keep that nurse, doctor, or technician from becoming so frustrated that they decide to leave the profession. That in turn increases your cost. So now you're looking at having to recruit more people into a system that really needs to have some continuity. It's very difficult. I can start at the beginning with recruitment of diverse staff. There are still at least, there are approximately 800,000 nurses needed in the country right now. We are short of that many nurses. We have been short of that many nurses for a long time. The interesting thing is that we continually say that we can't find a way to get new nurses into the pipeline. However, what we're doing in the USA is frequently we go out to countries like the Philippines, Thailand, and we recruit nurses to the USA. That's all well and good, but at the same time, if you look in certain inner city or poorer neighborhoods, you will find that there are so many young kids there who would love the opportunity to be given a scholarship to go to school, who would be such an amazing part of that healthcare system if someone thought through way in advance, how do we get the most vulnerable kids in our neighborhoods to actually be active parts and productive parts of our society? So in diversity and cultural competency in the healthcare pipeline, I may also be looking at how can you ensure that we don't have that healthcare shortage of the future. One of the most important things I do is talk to healthcare organizations about the need to do a comprehensive assessment of what is going on. I've had people ask me to come in and try to find out, why are the Hispanics unhappy? Why are the Asians unhappy? Why are the women unhappy? I would say to them, why don't we do a comprehensive assessment to see what is the happiness level of the entire staff? That way we're not segmenting people and polarizing a group that might already be somewhat polarized by deciding that one group needs to have attention and another does not. I would go in and do a comprehensive assessment. That takes a lot of work in advance. I have to work with the leadership, not just the one person who's the diversity chair for the organization. Work with the leadership to decide that they are going to walk the walk and talk the talk, and to go out there, do an assessment that's anonymous and confidential, that later I can get those metrics that show that a woman in the 20 to 30 age range in the radiology department is very unhappy, or that women in general in that department are really unhappy. It will also go through to help highlight what's making them unhappy. So frequently we think it's a question of race and ethnicity and culture and country of origin. Many times it is simply an issue of the fact that you have a new manager who has never been trained to be a manager. They were just a very good nurse or a very good radiologist or a very good physical therapist who has now become the head of that department because of their clinical skills, and no one has bothered to give them management and supervisory skills. So not only are they scared to death in the role, they are also now trying to manage their peers, and they have no idea how to deal with the simplest communication issues. An example might be, I say to you as the lab technician, I want you to get some blood from Miss Johnson. You say, okay. Later I come back and that technician hasn't done what needs to be done. And I say, well, why haven't you done this? And they say, well, you didn't tell me when. I had these other 10 things I had to do. So if you would tell me simple communication things that get compounded when you have cultural, racial, and linguistic issues. So I remember working in Saudi Arabia at one point. That really is what got me involved in working with culture and diversity. Not so much that I grew up in the segregated South, but because I went into an environment that I worked with people from 33 different countries. So I'm a preacher's kid, and I was in Saudi Arabia. As you know, Saudi Arabia, the whole idea of male-female interactions is not a thing that you do. I'm standing in the nurse's station just trying to get some things done, and a guy who was also a nurse from the UK came in, and he said, Valda, where were you? I came by last night to knock you up. My face just went, what in the world is going on? Obviously, I'm a PK. You're talking about knocking me up. I don't think I know you that well. And exactly why are you telling anyone in the meantime? So it's so funny. I was standing there red-faced and flustered. Everyone else was cracking up. It was because knocking up to him in the UK meant I came by and knocked on your door last night and you weren't there. Simple communication. With that, I was able to say, what's going on? Why are you laughing? People told me, I understood that that was a linguistic thing that meant nothing to him, but from my experience, to knock someone up meant, of course, to get someone pregnant. It was a very interesting thing, but I work with people from 33 different countries. We had people who came in with different backgrounds in healthcare, different ideologies about how to do healthcare, different beliefs about the rights of the patient. So it was very interesting, and our recruiters just brought anyone in and didn't think about how we would mesh together. So I started there developing systems that would work efficiently, effectively, and to make sure that the patient had a great outcome in the end. So these are the things I've developed from there and gone on to use those same things in any healthcare organization to determine, one, let's start with an assessment of where people are. Secondly, when we get the information, let's use it, because when they see that their concerns are being addressed, they're more willing then to make the changes that will make the whole organization work better. And that usually filters down to better patient care, because you have more satisfied, more effective employees who believe that you care about them, and that transfers into the patient care arena. Hospitals and healthcare organizations are in the unique position of having people from every walk of life enter their doors. They also want to make sure that when they leave their doors, they leave on their own accord, that they leave feeling that they had great care. In order for hospitals to do that, they have to use diversity and inclusion as a strategy, not just as something they add on, not just as something they have one half of an employee doing one half of the job. They have to look at it as not only a means to improve patient outcomes, but to improve employee satisfaction and to increase their bottom line. There are so many studies to show that having a good diversity and inclusion strategy is going to decrease your need to recruit people, is going to increase your ability to retain good people, and it's going to decrease your liability from malpractice and negligence suits because of lack of or inappropriate communication from a cultural context.